Hello, you stunning ones. This is Dr. Achla, the Harrison resident, and today I will be discussing a topic of so much confusion and a neglected topic, but yet a crucial one: interstitial lung disease. Now, I know this topic is a bit long, but don't worry, I won't be boring you much, but I have kept the notes short and crisp so that there is better understanding and let's remove all the confusion for once and all. So, let's roll on. Starting with the definition: interstitial lung disease. It is said that it is a diffuse parenchymal lung disease, affects the lung parenchyma with inflammation and fibrosis. The region between the epithelium and endothelium is involved. The symptoms include progressive exertional dyspnea or persistent dry cough. So this is a table from Harrison. So it is consisting of major ones, okay, major illness including the interstitial lung disease. Now starting with the IPF. So IPF is nothing but interstitial pulmonary fibrosis. So we have the clinical symptoms. Now the clinical symptoms of IPF. So there is a gradual onset of shortness of breath, dryness of cough, right? Then the physical examination findings say there will be frequent rales or the V's, right, at the lung bases. Along with that, we can see digital clubbing. Then the risk factors, most of the time idiopathic or the genetic findings, right, and also smoking. HRCT findings. Now HRCT findings suggest subpleural reticular changes, okay, including most of the prominent posterior lung zones. There is traction bronchiectasis, yes, we have heard that word, and honeycombing pattern. So this is actually considered as a usual interstitial pneumonia pattern, okay. On the histopath, we have honeycombing, right? So there is a fibroblastic foci. Now this is included, right, the fibroblastic foci. Now this contributes to a bad prognosis, right? We will learn why in the due course. Then the mortality rate is like 50% in 3 to 5 years of clinical symptoms. Then a non-specific interstitial pneumonia, NSIP, okay. Now the clinical symptoms include there is a subacute onset of shortness of breath, dry cough. Now this has to be remembered. Why? Because there is a gradual onset of shortness of breath in IPF, and non-specific includes a subacute onset of shortness of breath, right? Then there would be V's or the rails, okay, but the clubbing is not present. So this is a differentiation, right? Then the exposure one, most of the time idiopathic, or we have associated conditions. So we'll see what are the associated conditions, okay, like rheumatoid arthritis, or we have systemic sclerosis. Then the HRCT findings. HRCT findings suggest reticular pattern, okay, fair enough. In IPF also we have reticular pattern. There is traction bronchiectasis, right, but the honeycombing is rare in this, okay. So this honeycombing being rare gives us better prognosis than that of the UIP or IPF, okay. Then the histopath says that there is a cellular pattern or a fibrotic pattern, of course, but there is a cellular pattern. So the mortality being 18%, right, so it is less, okay. It is 50% in IPF, it is 18%, and 5-year mortality within the range of symptoms. Then there is something which is actually a respiratory bronchiolitis associated ILD. Now this is major seen in smokers, okay. Now they may be asymptomatic or have shortness of breath and cough, okay. So you can see most of the interstitial lung disease have similar symptoms like shortness of breath, cough. Then wheeze is common, clubbing is rare again, strong association with smoking, as I said. Then what would be the HRCT findings? There will be diffuse patchy centrilobar ground glass nodules. Now this GGOs, that is the ground glass opacities, is mostly seen in ILDs, other forms of ILDs other than that of IPF. Okay, IPF or NSIP. So GGOs should not be used for describing any of the disease. Okay, we need to look for the symptoms. We need to look for the other histopathological findings, whatever we are going through the slides and everything, and also the age factor, the associated comorbidities, okay, associated conditions. We need to look all of that. Then the histopath says there would be pigment laden macrophages. Now I will be discussing only and only the key points in this, because it is most important to know the key points, because the MCQ or any of the subjective tests will say the there is this person who is having a pigment laden macrophages or is a smoker, and then you need to relate upon, right? The mortality is 25% and 7-year mortality within that of the appearance of the symptoms. Then systemic sclerosis associated ILD. So the ILD, now the systemic sclerosis, wherein we have the puckering of the skin and thinning of the skin and everything. So I won't be going into that. I will be discussing the ILD which is associated with systemic sclerosis. So there will be gradual onset of shortness of breath. There will be dry cough, fatigue, okay, exaggerate cold response. Obviously, we know Raynaud's, okay. Then there will be difficulty in swallowing. Why there will be difficulty in swallowing? Okay, because of the crest syndrome which is associated, right? So we know the components of the crest. Um, then there can be rails, okay. There can be rails, okay. Also there will be skin thickening, joint swelling and telangiectasia, okay. So mostly that is an unknown cause. Obviously it is related to the disease itself, okay. And there is seen that the exposure to silicate and the solvent may be associated with it. So this is not so it is eventually we will be developing a habit of studying the only the key points, okay, only the association factors, only the exposure one. We cannot memorize everything, okay. So only the key points, that is it is related to the systemic sclerosis. The advances have said that there is exposure to silicates and solvents, okay. Then we have a UIP or NSIP pattern in this, okay. So UIP and NSIP patterns, and a dilated esophagus, occasional mediastinal calcification, pulmonary vascular enlargement. So both NSIP and UIP pattern, whatever we are seeing on the histopath, like fibroblastic foci and cellular pattern and everything, so that will be present in systemic sclerosis. 20 to 30% mortality, 10 year of within the symptoms, right? Then sarcoidosis. Sarcoidosis can be asymptomatic, shortness of breath, cough, like other ILDs. They have fatigue, palpitation, and skin joint findings. Okay, so what does it tell you about the sarcoidosis? Whenever we are hearing this word sarcoidosis, we have this panda sign, right? Why panda sign? Okay, there will be hilar lymph nodes involvement. Okay, so this can be normal. They can be presented with rails. Okay, skin findings are present, joint pain, and large lymph nodes. Now most of them, this also related to silicate dust, okay. So but it is idiopathic, okay. Most of the time we have the idiopathic course of this. Mediastinal and hilar lymphadenopathy, as we said, and a non-satiating granuloma, right? So this was a table. Why did I study this table? Because it is very important for us to remember each and every exposure, each and every clinical findings which are important to differentiate one from other, because the examiner will be telling you the key points, right? Next, the ILD of known cause and unknown cause. Now they have differentiated the ILDs. So this is also from Harrison. So ILD of unknown cause. So there is a exposure, okay. So we have occupational diseases like asbestosis and silicosis. Then the treatment related like radiation, methotrexate, amiodarone, nitrofurantoin. So these can predispose us for the ILDs. Connective tissue disorders like rheumatoid arthritis, scleroderma, dermatomyositis, granulomatous disease with vasculitis, with polyangiitis, shock stop. Um, HP, that is hypersensitive pneumonia is also associated, and sarcoidosis. Now the unknown cause. For the unknown cause, we have idiopathic interstitial pneumonia. Okay. Now this idiopathic interstitial pneumonia is divided into idiopathic pulmonary fibrosis and the other groups. Now this is the most important one because many people confuse between idiopathic interstitial pneumonia and idiopathic pulmonary fibrosis. So the interstitial pneumonia is uh, uh, having two groups, that is idiopathic pulmonary fibrosis. So it is a part of, right, and the other one has a non-specific interstitial pneumonia, respiratory bronchiolitis associated, desquamative interstitial pneumonia, cryptogenic organizing pneumonia, acute interstitial pneumonia, lymphocytic interstitial pneumonia. The other include lymphangiomatosis, pulmonary alveoloproteinosis, Langerhans erythrocytosis, pleural parenchymal fibroelastomatosis. Okay. Now the diagnostic approach. So what is the age? Age should be more than 50s or 60s. Okay, not seen in the younger age group. So atypical CT chest findings include UIP, that is a pathologic hallmark for IPF, that we have already seen that. The sex. Mostly the connective tissue disorder are present in females. We see joint pain and everything. But in males, because of the occupational exposure that we have seen, that occupational diseases are associated with it, right? So we can say that males are more predisposed. Also, RA is more common in female, but RA, which is associated with ILD, is more common in males. So the lymphangiomatosis, that is mostly in women. Most of the CTD are associated ILD, that is connective tissue disorder associated with ILD, is more common in women, except for the RA, that is males. Then the occupational exposure, so because of it, males are more predisposed. Then the duration and symptoms, mostly it is a chronic onset, but two of them there is actually exception to it. Whenever there is actually acute interstitial pneumonia, or we have the acute exacerbation of ILD, so these are having a acute onset. Okay, so these will be seen specifically, but they have a chronic indolent course. So there will be symptoms like dyspnea, cough, right? Hemoptysis wherein when there is actually diffuse alveolar hemorrhage. Otherwise, hemoptysis is not so common, or there is any secondary pulmonary infection like TB or something. Okay, obviously fatigue will be present. Then a past medical history related to the connective tissue disorder, Raynaud's phenomenon, and dermatomyositis associated cryptogenic organizing pneumonia, sarcoid-like reaction associated with malignancy. So medications: methotrexate, azathioprine, rituximab, TNF-alpha blocking agents, nitrofurantoin, amiodarone, bleomycin. The family history. So there are certain related genes. Okay, so I have covered in next few pages. IPF, NSIP, and desquamative interstitial pneumonia is associated with the genetics, right? Family history, it is hereditary. Now the social history: smoking, occupational exposure, environmental exposure, right? And hair-present pneumonitis again related to occupational. Physical examination, wheals or rails will be present, which is the earliest finding, right? Wheals and rails. So most of the time it will be confused with that of COPD, right? But remember, COPD will also have bronchi, okay, and bilateral spasm will be present. Advanced disease, we have 3 C's, okay, cyanosis, clubbing, core pulmonary. Easily we can remember core pulmonary because related to COPD. But also clubbing will be present and cyanosis. Clubbing, why? Whenever there is fibrosis, clubbing will be present, and of course cyanosis because he won't be able to breathe enough. Then the pulmonary function test say restrictive pattern, fibrosis, related to fibrosis. So the total lung capacity, FE1, FEC, DLCO, all will be decreased. Now there is a exception to it. Exceptions are always MCQ. Obstructive plus the restrictive pattern seen in LAM, HP, sarcoidosis. Okay? Chest X-ray. What does chest X-ray say? Sarcoidosis. In sarcoidosis, we'll be seeing hilar lymphadenopathy. Along with that, there is a central nodular opacity. In idiopathic pulmonary fibrosis, we have basilar reticular pattern and small cystic space. So I don't think so chest X-ray you would be able to recognize things. Okay, no one would be. other than that of a DM or someone, right? Of course, hilar lymphadenopathy, yes, we will be able to, but a reticular pattern and the small cystic phase more prominent in HRCT. But this is a MCQ. If anyone asks you, you should be able to know this. Then we should be performing a fiber optic bronchoscopy. Now, serial lavage fluid should be done to diagnose the diffuse alveolar hemorrhage. Okay. Whenever there is eosinophil count which is more than 25%, suspect chronic eosinophilic pneumonia, of course, in the name itself. So it should be a more than 25%. Fat globules present, lipoid pneumonia. Okay. Now, idiopathic interstitial pneumonia divided into idiopathic interstitial fibrosis and non-specific one. So this is more common. So idiopathic interstitial pneumonia, we will study one by one. Okay, we have already seen in the flow chart in the table itself. Okay, but little recap. So idiopathic interstitial pneumonia, which is the most common one, 50s and 60s, only in the elder one, right? Males one, right? Smoking, yes. Prevalence which increases with the age, direct proportional to the age. Poor prognosis, we already know that 50% of people will die within 3 to 5 years, right? The UIP pattern we have already seen three things: subpleural reticulation, honeycombing, traction bronchiectasis. So there will be extensive ground glass opacities along with it. There will be bronchovascular changes, micronodules, mosaic attenuation, upper lung predominance. Okay, so it has upper lung predominance, mosaic attenuation, micronodules, bronchovascular changes, extensive ground glass opacities. Histopathology, fibrotic pattern, yes, honeycombing present, fibroblast foci, right? So treatment. Now the treatment is most of the ILDs we have a treatment of supportive management, oxygen supply, okay, or we have certain antifibrotic which have been coming up. So perfenidone, right? So we have been describing perfenidone. Okay. Now dose is 200 milligram TDS or BD dose depending upon the exacerbations, right? And lung transplantation, of course. So here we can have an image, right? So this is a type of honeycombing, right? This. Then honeycombing and UIP, okay? This one. This is UIP pattern. Then we have a non-specific interstitial pneumonia. Now, non-specific means ulta of UIP. So it includes females, non-smoker. Of course, females are most of the time non-smokers. Fifth decade, it has a better prognosis. Associated with CTD condition like we have already seen RA and systemic sclerosis. HRCT, no honeycombing. This is very important. If you see this pattern, never mark NSIP. This pattern only in UIP or we have interstitial pneumonia. So histopath says mostly it is a cellular. If it is a cellular, better prognosis. Treatment includes prednisolone, we can try on, mycophenolate, azathioprine, cyclophosphamide, rituximab, antifibrotic therapy. Now these all do not cause remission. Remember that. There can there can be any of the exacerbation, okay, of the ILDs. But symptomatically we can say relief is seen. Then smoking related ILD. So there is this respiratory bronchiolitis ILD and we have the desquamated interstitial pneumonia. So there would be a active tobacco exposure, right? Active or prior tobacco exposure. DIP occurs in children with a familial pulmonary fibrosis, right? So this DIP has certain genetic factors, okay, related to genetics. 40 to 50 years of age, dyspnea and cough as a symptom. HRCT, what does it say? Now there would be a bronchial wall thickening, okay, peripheral wall thickening, central lobular nodules, ground glass opacities, GGOs, septal lines and reticular pattern. Now how do we remember all of this? So I have remembered this. See, a smoker who wants to smoke will go to some distinct place, right, towards a wall or something, okay. So there should be a bronchial wall thickening, there should be a peripheral wall thickening. I have remembered this. You can use this or you can make your own story. There is a central lobular nodule, there is GGO, septal line and reticular pattern. Honeycombing is rare in this. Now histopath, what does a histopath say? I have already said pigmented macrophages within the lumen of the respiratory bronchiole and alveolar ducts. Chronic inflammation with peribronchial or bronchiolar fibrosis. DIP, diffuse interstitial pneumonia. So it has a diffuse pattern, D, right? Remember 3 P's. Pigment macrophage accumulation, like in respiratory bronchiolitis, pneumocyte hyperplasia, prominent interstitial thickening. DIP has 3 P's, okay? Remember as DP, Deepika Padukone or anything, okay? So DIP has diffuse pattern, pigment macrophage accumulation, pneumocyte hyperplasia, prominent interstitial thickening. Treatment includes the same prednisolone, azathioprine, cyclophosphamide, smoking cessation program. Treatment part is not so very important, okay? Then there is a cryptogenic organizing pneumonia, okay? 50s and 60s again, subacute flu-like illness like cough, dyspnea, fever, fatigue, rage. Pulmonary function says restrictive pattern. Now, this cryptogenic organizing pneumonia is confused with other normal pneumonias also, like bacterial or something. So, remember, it can occur in isolation, not like contact or something. It can occur secondary to the malignancy, CTD, and medication. Okay. HRCT says, now the HRCT is very important finding. Okay. Patchy, migratory, it can move. Subpleural consolidative opacity with ground glass opacities. Peribronchiolar and perilobar opacities. So here I have a diagram. Ground glass opacities seen. This is the ground glass, right? We have a atoll or a reverse halo sign. There is a thin rim of subpleural sparing. Okay, so here there won't be any opacity seen. Perilobular pattern, fibrotic pattern, band-like opacities, nodular pattern, and parenchymal consolidation. Okay. Histopath says there will be a granulation tissue in the small airways, alveolar and alveolar ducts. Treatment includes corticosteroids, mycophenolate, cyclophosphamide, rituximab. Then acute or subacute ones. Now acute interstitial pneumonia, which is also called as Hamann-Routh syndrome. Okay, acute means acute onset, right? Respiratory distress, hypoxemia. Now it is a very fatal. Now if it is happening acute, no time, death. 50% mortality, more than 50% in 6 months of the onset of the clinical features. Within the 6 months, 50% mortality. There will be acute respiratory tract infections. Recurrence is very high. What will be present? HRCT includes GGOs, right? And diffuse alveolar damage, DAD. Also seen in COVID. Similarly, like that of ARDS and acute exacerbation of pulmonary fibrosis. We'll be seeing the next topic, right? Treatment is only supportive. Acute exacerbation of IIP, that is also acutely occurring, acute hypoxemia occurring, acute respiratory tract infection occurring, then mortality is very high, more than that of the 85%. Now this occurs as an accelerated lung injury by pulmonary fibrosis, which is seen in ILD. So like COPD, already there is this lung injury, but there is an acute exacerbation to the lung injury that has happened. Acute onset respiratory infection, hypoxemia, GGOs again, DAD again. So supportive, prednisolone, nintedanib and cyclophosphamide. Okay? So DAD is common in both, then GGOs is common in both. Mortality is very high in both. Then the ILDs, which is associated with connective tissue disorder. So we have a systemic sclerosis, the first one. The most important one, which is related to ILD. Okay? We have two types of systemic sclerosis, a limited one and diffuse one. Okay, diffuse ज़्यादा बड़ा 50%. Okay, so 50% of them have associated with ILD, 50% of diffuse one, 30% of them of the limited one is associated with ILD. The limited one is related to ILD in way that there would be development of pulmonary hypertension. Okay. Now the HRCT says NSIP pattern, IPF pattern, cryptogenic organizing pneumonia or DAD. Dilated esophagus, pulmonary artery enlargement. So it is like NSIP or UIP pattern. Okay. Treatment includes cyclophosphamide, mycophenolate, antifibrotic therapy, esophageal dysfunction, lung transplantation. So there would be a MCQ which is saying that puckering is present, he cannot gulp or he cannot swallow. Along with that, there is some joint pain, Raynaud's along with it, and of course there would be certain dyspnea and shortness of breath over the course of time. So it will say what is it. So you need to find out the diagnosis. Then rheumatoid arthritis. Common extra-article complication is ILD. So the most common one which is related to ILD connective tissue disorder is the systemic sclerosis. The rheumatoid arthritis, the most common extra-articular is the ILD. Okay. Females, we have the common RA. Okay. But RA ILD is common with males. Clinically, only the 10% have ILD. Like we can suspect clinically as a interstitial lung disease. We are having interstitial lung disease in this patient. Only clinically we can subject to it, right? Only 10%. Radiologically, we have 40 to 50%, right? Because there will be certain patterns like NSIP or UIP pattern will be present. So we can differentiate like, yes, it is an ILD. But clinically, no one can say this is an ILD because rheumatoid arthritis also will be having rheumatoid pleuritis along with it or pleural effusion associated with it. HRCT, we have UIP pattern. Histopath, we have UIP and an SIP pattern. So the UIP along with the rheumatoid arthritis, there will be decrease in fibroblastic foci and increase in amount of germinal center. Okay. Treatment includes prednisolone, mycophenolate, azathioprine, cyclophosphamide, and antifibrotic agents. So next we have dermatomyositis. What is it? It is an immune-mediated destruction and dysfunction of the muscle. So what does it affect? Skin, joint, CVS, lungs. So ILD, 45% of the patients we have anti-synthetase antibodies present. So in the ILD, if it is related anyhow to if the dermatomyositis patient develops ILD, 45% of the patients will be having anti-synthetase antibodies, which is positive. Now, what is anti-synthetase syndrome? It is nothing but it has antibodies which is positive. Along with that, there will be myositis. In the name itself, there will be fever, Raynaud's phenomenon, mechanic's hand, arthritis, progressive ILD. Okay. So 6 features we need to know. Anti-Jo1 antibodies, if it is at all positive, there would be rapidly progressive ILD and there will be acute exacerbation seen. So it is a bad one. Dermatomyositis or the polymyositis, it can be associated with malignancy or isolated CTD. HRCT says most commonly we have NSIP. Also you have UIP pattern, but most commonly it is an NSIP pattern. So you need to remember dermatomyositis, polymyositis, NSIP pattern. Okay? Histopath, NSIP, COP, cryptogenic organism or UIP pattern. If it is an acute exacerbation, we already know that there is DAD and GGOs will be present in the acute exacerbation. So treatment includes prednisolone, azathioprine, mycophenolate, cyclophosphamide, calcineurin inhibitor. Now, if it is a granulomatous ILD, so we have sarcoidosis, we have hypersensitive pneumonitis, and we have inorganic cause. Granulomatous means it doesn't mean they have the caseating granulomas like that of TB. It can be non-caseating also, that is seen in sarcoidosis most commonly. Okay, so vasculitis, that is the blood vessel which is involved, inflammatory infiltrate present, granulomatous lesion present, tissue necrosis will be. Lung involvement, if it is at all, then there will be hemoptysis present, okay, mostly because of diffuse alveolar hemorrhage. In Wegener's disease, we have the patchy migratory ground grouse consolidative opacities with a hilar lymphadenopathy. Involvement of lung, ear, nose, throat, kidney. Okay, kidney में RPGN. Then there is a eosinophilic pattern, that is a Church-Strauss syndrome, involvement of lung, right? And along with it, chronic sinusitis, asthma, and peripheral eosinophilia. Then the genetic part. So there will be a mucin 5b TERT, then TERK gene, telomerase RNA component, RTEL1 gene, telomerase elongation helicase 1 gene, surfactant protein A2, okay, and sarcoidosis is associated with IL-12B and BTNL2. Thank you for watching.